Okay, good afternoon, everyone. So our time is limited, but inshallah, in those 10 minutes, I'll try to just to focus on the broader, let's say, concepts. And of course, feel free to go through the slides, read any references you find helpful, and feel free to ask me any questions in my office or during Sunday's session. So very briefly, we hear that term, tumor markers. What does it mean? So we use this term to basically refer to any biological substances in the body. These biological substances, they could be a hormone, it could be an enzyme, it could be a receptor. So really, it could be found in the blood, it could be found on tissue, it could be found in the urine. So any biological substance in the body that could indicate potentially the presence of a cancer, we give it a general term, which is tumor marker. That is very important for various reasons, like drug development, molecular profiling for the tumor. And essentially, we can categorize them into three main categories. Number one, tumor markers could be tumor specific. It means if you find them, then there is malignancy. Like, it's not linked to any other benign disease. It's linked to the presence of a malignancy. And I'll give example of this. It's essentially, you could technically classify Philadelphia chromosome as a chromosomal abnormality related to malignancy. All right. The other more common category would be non-specific proteins related to malignant cells. It means if you see them in higher amounts than usual, they could indicate potentially presence of malignancy, but it could also be present in higher levels, for example, in other benign conditions. And finally, there's cell-specific proteins overexpressed in malignant cells. How is this different than the previous one? Over here, you're talking about something that is commonly expressed, normally expressed, but if it's more than normal, then it's considered a tumor marker. PSA, prostate-specific antigen, falls under this category. Very quickly, for the interest of time, I'll go through examples, and once you know the examples, you'll be able to know the difference between those three broad categories. So tumor-specific, it means they're only expressed in tumor cells. Best example is Philadelphia chromosome, which is a chromosomal abnormality. It's essentially translocation between chromosome 9 and 22. That leads to a fusion gene and an abnormal protein, and that is associated with leukemias, essentially. All right? So you don't find Philadelphia chromosome in normal cells. So it's only in conditions where there's abnormality in stem cells or hematological malignancies. The other category, which is non-specific proteins related to malignant cells, the best example would be the oncofetal proteins. So oncofetal proteins like CEA, or carcinoembryonic antigen, or alpha-fetoprotein, those are what we refer to them as oncofetal proteins. They are at one stage expressed in high levels, maybe during the fetal life, during development, but as the cells differentiate, the levels will go down. However, one of the hallmark of cancer cells, sometimes they have features of, let's say, stem-like features, so basically they de-differentiate. As they de-differentiate, this is accompanied by increase in expression of such proteins. And for example, alpha-fetoprotein could be found in hepatocellular carcinoma, other cancers. CEA is found in 30 to 50% of patients of breast cancer. But remember, this is not an abnormal protein. It is normally present, but as the cells differentiate, the expression goes down. So if it's reactivated, it's high, that could be related to malignant presence. But you can see there are benign conditions that could show high levels of these markers. And then finally, the cell-specific proteins that are overexpressed. The best example, prostate-specific antigen. Do prostatic cells express it? Yes. Under normal conditions? Yes. If it increases further, it could be benign prostatic hypertrophy, or again, depending on the family history, the level, it could indicate cancer. So all of these are great. They help us maybe potentially detect malignant presence, but if you really want a good tumor marker, then ideally it should be only produced by the tumor. It should be present in early stages of cancer. Unfortunately, that's not always the case. So you can detect the cancer earlier. It should distinguish between benign conditions versus malignant conditions, and so on. But again, we do not actually have a single, we don't really have that privilege of having a good specific tumor marker. Otherwise, that would help us use such markers in maybe diagnosing or screening cancer. So we don't really have tumor markers that could screen in a very effective way. That is just to show you don't need to memorize particularly this or everything under this tumor marker. Maybe focus on those that are commonly used in clinical practice, and I do have a few of them at the end. But what I wanted to show from this is that they could be enzymes, they could be hormones, they could be receptors, glycoproteins, really any of them, depending on the context, could be considered tumor markers. So theoretically speaking, you could use tumor markers for screening, diagnosing, prognosis, to evaluate if, for example, your treatment, let's say following surgery. But the most common uses would be monitoring treatment response, surveillance for recurrence, and also sometimes to identify therapeutic targets. So if you know that this breast cancer it has HER2, I'm sure you've heard of HER2 expression, right? So if it is positive for that receptor, then maybe you can use Herceptin. If it's estrogen receptor positive, you can use hormone therapy, and so on. So I would say the ones in red are the more or most common uses of tumor markers. We understand screening, it's not very effective because sometimes it's only present, these markers are only present in high enough levels in late stages. So you don't want that, right? Same thing with diagnosis. You know that we always depend on histopathological analysis and so on. All right, so there are things that I feel are redundant. For the interest of time, I'll try and go through them quickly. But remember, tumor markers could be receptors. So in breast cancer, these receptors could be estrogen receptors, progesterone receptors. And if these are present in the cancer, it usually is associated with better prognosis, and it could be targeted by certain adjuvant hormone treatments. You have your HER2 receptor or oncogene. It may be overexpressed in certain types, while it is associated with a more aggressive, usually cancer. So lower, usually estrogen and progesterone receptor positive are slower growing and associated with overall better prognosis. However, HER2, they tend to be more aggressive, but at least you can also target them with Herceptin. And then you have your triple negative. There's no HER2, no estrogen receptors, none of these classic tumor markers. That gives you less opportunity to have alternative treatment options. You're stuck with the standard chemo, radio, surgical intervention. So overall, it is associated with worse prognosis, not worser. All right. There are other markers. I'm not going to talk about the genetic markers. This was described by Dr. Shaheen. You have cancer antigens. So it's important to know at least CA153, CA2729. CA153, sometimes it's high in advanced breast cancer. So patients in stage 4 maybe with metastases would typically may express higher levels of cancer antigen 15-3. So it has a higher sensitivity for metastatic disease. Of course, much like a lot of tumor markers, it is also expressed in various other benign conditions. So over here, that's just a table that describes different cancers and different markers related to those cancers and the recommended use, whether it's recommended for monitoring or screening for recurrences. And I'd like to end with this table. I know there are a lot of tumor markers, but you are expected to know the ones that are commonly used in practice and also the ones that are associated with breast cancer. So these, you are expected to know them. So there's alpha-fetoprotein. So now, not just now breast cancer, no, I'm talking in general. So there's alpha-fetoprotein. There is prostate-specific antigen, and that is basically can be used in screening for prostate carcinoma. CEA, or carcinoembryonic antigen, it's associated with colorectal cancer, other GI cancers, and certain types of lung and breast cancers. CA125. So in patients with high probability, or maybe there's a family history of ovarian cancer, or they could have other gynecological conditions that puts them at risk of ovarian cancer, like endometriosis, this could be a screening tool, but it's essentially associated with ovarian cancer. And there's alkaline phosphatase. That could be a marker as well of bone metastasis. And again, I like to show this because I find it interesting. Beta-HCG, again, so anything could be, in a way, a tumor marker. So you have over here a hormone that is associated with pregnancy, a very positive physiological event. However, in a different context, in a male maybe with certain symptoms, the presence of beta-HCG actually indicates testicular cancer. So that is the concept as a whole. I hope I finished on time. Perfect. If you have any questions, I'll be here in review session on Sunday, but also please do not hesitate to come to my office anytime.